Good afternoon and welcome everyone to today's webinar session, Keys to a Successful Chargemaster Review. We're almost up at 2 o'clock Eastern, so I still see some people dialing in, so we'll give everybody another minute or so here to sign in and get settled, and then we'll get started with today's session. All right, welcome everyone. We're going to go ahead and get started today. There's probably still a few people signing in, but it is 2 o'clock Eastern. We have a lot to cover, so we're going to go ahead and kick things off. So again, welcome everyone. Today's session is focused on keys to a successful Chargemaster review and how to really balance these new price transparency demands with your organization's net revenue goals. So just some brief introductions about today's speakers. I'm Brad Josephson. I'm the Director of Marketing here at PMMC. My role today is going to be moderator. So I'm going to be posing questions to our experts today, Greg Kay and Tara Bogart. Both have years and years of experience with strategic pricing, working with hospitals and healthcare providers, trying to meet objectives related to net revenue. And those types of things. So happy to have them on the call today. And I'll give you a brief preview of our agenda here. Greg's going to kick things off and give us an update on the new price transparency mandate that will be rolling out January 1st, 2021. And then we're going to give you some real world ideas and strategies for how to integrate these new mandates into your overall pricing strategy. So Tara's going to share some things that she's seen through her experience working with hospitals with strategic pricing projects, and we're going to start thinking forward about how this is really going to impact pricing at your organization going forward. And then we're going to wrap up and talk about how we really make a transition from strategic pricing to rational pricing. So before we go ahead and get started, we know that everybody on this call is going to have to go through their annual Chargemaster review. So the first poll question here, just to get a gauge of the audience, this is an easy one. What is your hospital's fiscal year end? So go ahead and answer that question, and we'll get everybody's responses here, and then Greg will lead us off with the updates on the CMS Final Rule. All right, looks like most people have responded, and it's pretty evenly split across the board. About a third of you have your fiscal year end coming up pretty soon here, June 30th, actually about 40%, and then 20% are September 30th, and then another 40% or so are calendar year end, December 31st. So thanks for voting, and I'm going to turn it over to Greg to lead us off on the final rule.
Great, thanks, Brad. We do appreciate everyone joining us today. And as we know, this time last year, CMS had just issued an updated mandate requiring most hospitals to follow through with prior price transparency requirements going back to the Affordable Care Act for hospitals to post their charges along with the average charge by DRG. And the industry, if you will, responded with most hospitals just posting a basic CDM file, one column with the CDM charge code description, the second column with the unit price for thousands of charge code line items. And while this was, as we know, the first step towards providing some level of transparency, I think there's an industry-wide acknowledgement that that was a very small step and really provided very little insight for what consumers were looking for in terms of understanding how much healthcare services really cost. And this response, if you will, is probably a partial reason why the President issued an executive order last year requiring 5 departments to review current laws and regulations to identify ways to really improve the transparency of both pricing and quality data available to consumers searching for healthcare services. And this led to draft rules in August and final updated rules in November. And it's noted here, the bullet points. The final rules, CMS really incorporated the industry's feedback, and they incorporated some updated definitions to hospitals' standard charges and items and services. They clarified the requirement for posting your list of standard charges. They incorporated some new requirements as well as options for shoppable services. And this is definitely an area that CMS appeared to have listened and incorporated a lot of our suggestions from the industry. And then outlined specific action steps for those not in compliant, and probably most important to many of us, move the effective date back to January 1, 2021, which is a big relief, I believe, for everyone. So with the extra time, I think the big question now is, what most of us are asking is, how do we really move from a strategic price mindset to a rational price mindset that begins balancing new transparency requirements where the consumer really wants to understand why charges and reimbursement are set as they are. And there's going to be a larger desire, if you will, as we try to find that right balance to maintain net revenue levels that meet our community needs. So whether or not CMS has the legal authority to mandate this level of price transparency obviously remains very unclear. And just a few days after the final rules were released, several major hospital groups did move forward with a lawsuit challenging these new requirements. So before we take a deeper dive into strategic price considerations, I think it's important to note that there are pending legal suits that will be moving through the courts this year. Obviously, these suits have asked that the implementation of the final rules be blocked. The legal actions, if you will, really focus on 2 primary points. The first is that the new rules create an undue burden, and the suit points out that it does potentially undermine competition. So it's safe to assume that this will ultimately end up being decided by the courts over the next few years, but it will likely not stop CMS from pursuing this implementation during the period. So it's also key to remember that this legal debate will also occur in the middle of an election year. So it will also be debated in the court of public opinion. And obviously, we all know there's a growing frustration with the unaffordability and the lack of cost information that's available today. Unfortunately, hospitals and payers will likely be easy targets for this backlash. And thus, there's going to be a new level, a new need, if you will, for explainable and rational pricing. So as a quick level set, as we're thinking about how we're going to be adjusting our charges from a strategic pricing standpoint, just as a level set with what CMS is requiring in the final rule, they provided some additional detail and specific examples with the two baseline requirements. The first being related to hospital charges. CMS clarified the definition of standard charges. And standard charges now must include 5 components. Gross charges for items and services reflected on the hospital CDM, the discount cash price, which is the cash price for a patient that pays at time of service. And this requirement was added, again, based upon our hospital industry comments. The payer-specific negotiated charge, which obviously is one of the more controversial items. And lastly, the 2 other components being the de-identified min and max charge that lists your lowest and highest negotiated rate for each line item in service. The second requirement that CMS included, that again ties back to strategic pricing, is the requirement around a list of shoppable services. Based upon comments from the industry, the final rules now have 2 different options. We can post a comprehensive machine-readable file, or we can utilize a consumer-friendly patient estimation tool. And CMS has acknowledged that many hospitals do have self-service estimation tools, and that really would be their preference because it does allow patients to create an estimate of their cost prior to a service. And those tools will now meet the mandate requirement because at the end of the day, consumers want to understand their cost, which is often less to do about detailed charges. And these tools do provide that ability in truly a more efficient way. So the file format that you posted January 1st of this year can follow the same format as last year. But for 1/1/2021, this will need to be expanded to include an easily understood description, related CPT HCPCS codes, as well as other relevant codes such as NDC codes, volume amount per customers, to really more clearly understand your charges as we have outlined here on screen. Now, for multi-facility organizations, the price is going to have to be facility specific. And if you do have tiered pricing in your CDM, in other words, a different charge rate for different service settings, those should be listed along with the related service location. Now, the cash price that's noted here in column G with this example shows a 55% discount for those patients that pay at time of service. And again, CMS clarified on a recent call that the definition of cash price doesn't necessarily mean the patient solely paying cash at time of service, but it can include the obligation to pay with a credit card or over time. Now, the last 2 columns on this example, H and I, they are the negotiated charge for all payers with a discount, where you have to then compute the min and max being the lowest and highest value across all payers. Now, the other component that CMS did include was that requirement for the negotiated charge for all payers with a discount. So in other words, if you have 30 payer contracts with an average of 2 plans per contract, you're going to have to create a file with 60 plus negotiated charge columns or 60 plus tabs with that information. One of the things that CMS did elaborate on in the final rules was this term service packages. And CMS shared that these can be listed in the same worksheet as your primary tab, extending on out from column I, or you can list it as additional tabs, as you see here on screen with the Aetna PPO, the BC HMO, the BC PPO example. You're going to have to list this for inpatient services based upon DRGs or MSDRGs, how your base rates are listed in your payer contracts, and on the outpatient side by CPT, APC, EAPG, with the various negotiated rates. Now, as it relates to the hospital shoppable services, CMS has indicated, again, they're providing a lot of flexibility with how the patient estimated cost is presented to the consumer. And they did provide some guidelines specifically related to there being a minimum of 300 shoppable items with at least 70 a part of the CMS provided list. And the estimate of these shoppable services must be available real time from your website, which means the current process of submitting request forms or posting a telephone number to call in will have to be upgraded to a more current means of gathering information. This is just prodding our industry to move forward, if you will. And it's also important to note that CMS did specifically call out the fact that these files, this data, needs to be available without restriction in any form or fashion. Now, the other option that CMS did note was with a self-service estimate tool. CMS did recognize that there is a need to capture certain patient demographic data, such as name, insurance group code information. So if you're going the patient estimation route, you've got a little bit more flexibility in the data that you can collect. But if you're just going the file route, it has to be unobstructed with that information being posted online. Now, the price transparency mandate is going to create some real challenges, one of which is how to implement this year's strategic price changes. And CMS has indicated that this process should only take us about 100 hours, but there are obviously numerous things that have to be considered. And not only that, is noted here, there's a layering process that occurs with each one. So this complexity ties directly to the question that today's session is centered around. So Tara, what are some of the key components to a successful Chargemaster adjustment that folks need to consider this year?
Thanks, Greg. Before we focus on how to change prices this year, let's recap what we've been doing in the past. Most organizations have gone through an exercise called strategic pricing. You guys all know it, and some of you are probably planning to do it again this year, but maybe even on a smaller scale. But it typically is an exercise where you change your prices to respond to contract incentives and minimizing losses from lesser terms. So as part of the strategic pricing process, which maximizes reimbursement, hospitals bring in market data to use as guardrails to prevent standing out. So it sounds fairly balanced since market data is part of the equation, but the truth is strategic pricing is the cause for many hospitals having some services overpriced and others underpriced. It's one of the reasons we're facing the pricing transparency challenge today. Strategic pricing doesn't leave hospitals with pricing that is rational to the customer or competitive with non-hospital care settings. So hospitals really need to rebalance pricing with the underlying value and begin to move commercial payment terms in that direction without losing margins in the process. Until the payers are willing to help you guys out and help realign pricing, you're still going to have to pay attention to market data. Still going to have to look at charge sensitivity of items, lesser terms, all the things that you've probably been doing, but there needs to be a strategy to move toward rational pricing. So we'll talk a little bit about those today.
Yeah, thanks, Tara. And on that point, we'd like to get a gauge from the audience as far as how you feel your organizations currently compare relative to your market today. And that's going to be our second poll question here. So if you could go ahead and take a look at this question and let us know where you stand today. So are you high-priced and can't afford to lower prices and lose the revenue? Are you at or just below the market? Or do you feel you could use maybe a few decreases to shoppable services and then maybe balance revenue in other areas? Or the fourth option, you don't know where you stand today. And I apologize, I just opened the wrong poll question, so we're going to go ahead and try that again. Sorry, everyone. Let's try that again. So how do your organization's charges compare relative to your market today? High price and can't afford to lower prices and lose the revenue? at or just below the market, could use a few decreases to shoppable services, or we don't know today. And we'll give everybody another 30 seconds or so here to vote. All right, looks like most of the audience has voted, and it's pretty spread across the board. So about a third of the audience believes that they could decrease shoppable services and balance their revenue in some areas. About a quarter of you say you're at or just below the market. 28% were candid and said they don't know where they stand today. And about 14% believe that they're high-priced and can't afford to lower the prices and lose that revenue. So we're going to talk about some strategies for each of these situations as we move on through the presentation. You can see the poll results here, and we'll share those after the call as well. So I'm going to flip it back to Tara here with a question. So Tara, what's your recommendations to hospitals this year that's really different from years past when they're looking at their Chargemaster?
Well, I think this year the industry is starting to accept that pricing transparency is really happening. I mean, of course, the timeline's debatable and the negotiated charge piece of the mandate is too, but the direction of healthcare is clear, and I think consumerism is here to stay, and we can't just adjust charges to affect the bottom line anymore. So we're going to have to apply some business economics to determine what services we truly want to be in, what services we can actually compete in, and negotiate our contracts and set the prices accordingly. So this year should really be the first of a long-term strategy that will help you be ready to compete.
Okay. So what about advice that you have for hospitals that just answered that they just need to decrease a few shoppable services? What about those providers?
Yeah, well, clearly from the poll results, it's not a one-size-fits-all. So for this group, lowering radiology and lab prices and offsetting this with increases to the areas like surgery or room and board, that's familiar territory. And most of the listeners on the webinar have probably been through that exercise. The difference today is that we aren't lowering prices just to compete with services performed at freestanding. The scrutiny is going to be all service. So back to your original question, what advice do I have? I would say to be intentional and be meticulous. So applying a charge sensitivity factor by payer to calculate the net revenue impact is an estimate. And when you're trying to walk that fine line between lowering your prices and protecting your bottom line, you're really going to need precision, not an estimate. So I recommend updating the claim data with your proposed CDM and running the claims back through your contracts. This will allow more accurate net revenue estimates, and it factors in lesser charges and outliers at the case level. Okay, and going forward, as we move from the traditional strategic pricing project methodologies to more rational pricing approaches, there'll be a need for more integrated and ongoing modeling of both changes to charges and the changes to payer reimbursement. So what you can see on the screen is, an important consideration is going to be the impact of lesser of contract terms and being able to see outlier reports, things like that. And for those of you who want to decrease a few charges, you need to monitor the impact of those areas. So this level of detail is critical. If you see your lesser charges start to go up with a scenario, you'll need to dig in and understand what codes you impacted that likely brought the cases down below. So in this example on the screen, this is showing monitoring your lesser of hits and your outlier hits. So the first column is your baseline, and so that's where your lesser of dollar improvement, hits are today. And then you've got your reprice scenario, the second column over. And so how many hits do you have today in your new scenario versus where you are today? watching these numbers, because if you start really decreasing prices, you could have that dollar impact positive on this scenario, this example, but if you start seeing negative numbers, you could be in trouble, and you're really going to want to know it.
Okay.
And so if you do find yourself hitting lesser of charges, which, you know, is so easy to do with so many of the contracts out there, you're going to need to drill in and look at DRGs and figure out where is this coming from. And in this example on the screen, you can see a lot of deliveries at the bottom. So the charges are in the $5,000 to $6,000 range, and the rate is $6,700. So, you know, potential loss per case is anywhere from $5,000, $8,000, $9,000 up to $2,000. So this is a great example of where hospitals really need to think about where they want to compete, because this is definitely a shoppable service. So is it worth the dollars that you're losing? You've got to think about volume, think things through. What do you want to do? And if you do want to, you know, just bump those prices up a little bit to get over that that loss, you're going to have to drill in one level and get to all the charge codes that are behind that DRG, and then figure out how can you isolate a few charge codes that don't run across services and try and impact that number. It's not easy. It's quite the task, but that's the process that we're going to have to do as things get tighter and tighter.
Gotcha. Yeah. So good discussion there, Tara, around lesser of charges, and I think that's a good pause for us to get an idea from the audience how they're monitoring their lesser of charges today. So that leads me into our next poll question here. And it looks like I had started this before, and unfortunately I can't get back into this poll question. So we had a few responses around this. How are you monitoring lesser of charges at the case level today throughout each Chargemaster scenario? So we got a brief sample, and it looked like about 63% said that this is part of their annual process. Another 25% said that they look at lesser of charges at the line level or the fee schedule level, but need to start incorporating more of this into their process. And then a lesser percentage, about 13%, said that they have monitored this before, but don't really worry about it being an issue since they aren't low priced. Yeah, and since we didn't get a chance to get everyone's responses, we'll send this poll question out after the session because we'd like to get a better sample size of how hospitals are approaching their lesser of charges today. So with that, we'll continue moving on to our next question for Tara. So Tara, what about areas in the Chargemaster that have been neglected but might get thrown into the spotlight because of this new mandate?
Well, the first one that comes to mind is the professional rate schedules. I'm always kind of surprised when I hear that that's an area that hasn't gotten much attention. And with the mandate including hospital-employed physicians, it's very important. So the professional side is typically much more straightforward, and this analysis can be easily done. There's comparative data out there, and monitoring lesser charges is super easy at the line level. So that's definitely a place that everyone should check the box to make sure they're doing. The other is pharmacy and supplies. Because it's on its own markup schedule, many have carved it out from their annual projects. And over the years, we found a number of hospitals that don't keep the cost and markup current. So some items receive their prices when they're originally set up in the Chargemaster, and they go on the markup formula, but they haven't been updated since. So in this example, I'll walk you through it. We're looking at the average surgery cases among competing hospitals, the bar graph, and the charges are broken up by revenue code categories, which are in the different colors. I know it's difficult to see on your screen, but if you just turn your attention to the navy blue bar, it represents supplies. And on the left bar, this is a large section, but in the other bars, the section is much smaller. So this indicates the hospital on the left has either a high charge or much higher utilization than the peers for supplies. So this was a red flag for one of our hospitals where we performed a review, and we had to do some major changes to get them more in line. But you're going to want to know this type of thing. You're going to want to know if you have some unusual practices before your prices are published with the standard codes, because now people can really make more easy comparisons.
Okay, yeah, that makes sense. So definitely think about pharmacy and supply. So what about those hospitals that are below the market? They don't have to worry about transparency, do they, other than compiling the necessary files?
In theory, yes, but I wouldn't recommend skipping an annual Chargemaster adjustment, because it can be an opportunity to improve your revenue or an opportunity to improve rational prices. So competitive prices is just one goal of rate projects. If your contracts allow for, let's say, a 3% price increase, you should review to see if you can take advantage of the revenue opportunity. Another component of a project is to make sure you have logical pricing. Are bilaterals priced higher than unilateral procedures, or procedures with higher with contrast higher than those without? Are charge codes done in different departments that map to the same CPT? Are they priced the same? Perhaps they are intentionally different, but you need to review these to be sure. We've seen many times that they're priced hundreds of dollars apart with no rational reason other than a service line manager made a change, and the price disparity just got high over the years.
Okay, so what about those hospitals who aren't lucky enough to be priced below the market? Can they really reduce charges without taking a significant impact?
Well, I can't answer that without seeing the contracts and the utilization at the particular organization. But over the past 10 years, we've done this a few times, at least walk through the exercise, and the results are mixed. So it's important to start with knowing where you are in the market. So as an example, we had a hospital that was 20% above local and regional competition. I don't mean just for a few services. They were really high across everything. And they knew it was from 10 years of price increases, 10% price increases to boost the bottom line. The organization was financially very healthy, but as leadership said, it was time to stop riding the gravy train. So they knew they faced a revenue challenge. They took a huge hit, but they wanted to go ahead and do that and get ahead of it instead of responding to losing market share. So PMC modeled a lot of scenarios and minimized the hit for them, but you know that was one experience. But we've had other hospitals that have looked to us to model decreases. Another one, there was a CFO who was tasked by the board to lower charges because they felt they could achieve a better market position without giving up net revenue because they had flat contract rates. So PMOC modeled scenarios and provided analytics to show how the net revenue trended alongside the gross revenue decreases. We're able to give them drill down analytics and kind of understand what was going on and provide some insight as to why a hospital with flat rates on all their large contracts couldn't successfully bring charges down without taking a hit. And in this case, it was a Blue Cross traditional plan. It had small volume, but it was significant enough to impact the financials. So for other hospitals, we've been able to have small annual decreases without impacting net revenue. These clients have recognized they have to take baby steps and spread the net revenue across a few years. But the key point is we need to begin changing our mindset away from strategic pricing projects and more towards rational methodologies that take into account the consumer and views the market differently. But sorry to keep going, but Brad, back to your original question of, can we really reduce prices without taking a revenue hit? I think my big takeaway from this question is don't be afraid to try. So whatever your goals are, you'll never get there if you don't do the analysis and understand the numbers. You might walk away without implementing the ideas, and we've seen that a few times, but you'll gain insight, and then you can take that insight to your managed care team and target specific contracts, language, terms for negotiation, just being in the know, if you will. So what we have on screen here is an example of a hospital not being afraid to accomplish lofty goals. They started with a list of 400 supplies that they didn't want to charge for anymore. So we made the adjustments and modeled the revised claims back through the payer contract, and it was a $21 million hit. So next we worked on balancing the impact and made some increases throughout the Chargemaster while paying attention to market position. So that made things look a little bit brighter. And then we took on radiology pricing. We wanted to target some items to compete with freestanding facilities, and we did a few iterations of that. So that's all that you're seeing there in the purple, and then in the red we kind of changed directions, tried out some other ideas. They didn't stop there. They took on draft 2 and said, well, what if we could stop charging for all self-administered drugs? And so this is an example, there's only a few columns here, but this spreadsheet runs really, really wide. And this is what I'm talking about as far as not being afraid to try and at least having the insight to know what you can and can't do.
All right, so we've been through a few scenarios of how hospitals can respond, kind of where they are based in their market today. But I want to get back to a point that we talked about in the beginning of the webinar, and I think this is important as we start moving forward in 2020 and beyond. We talked about the concept of moving away from strategic pricing towards rational pricing. Can you tell us a little bit more about really what that means and how that would parlay into a long-term strategy for hospitals?
Sure. So the first thing you need to do is broaden the conversation. So compile a team to address pricing. It can't be done in silos like it has been in the past. You'll want to involve managed care, marketing, revenue integrity, maybe someone from strategic planning or business development. And the groups need to analyze where they are today and where they want to end up. So recommend starting with an analysis of each service line. And for each service line, you need to know if you're competing with other hospitals, maybe a regional market, freestanding outpatient, hospital-based outpatient, lab retailers, retail clinics. I mean, it could go on. You just need to know exactly what space you're competing in, and you'll want to determine how you look today from a price standpoint for each area. What percentage of the market do you have today? Do you expect any significant volume changes? Are you bringing on 3 or 4 new docs and expect the volumes to increase? Is a competitor opening up nearby? And this is a big one, profitability. You need to understand that. Gather your cost data. Look at that by service line. Do you have a service that's really low margin? You need to flag it and come up with a strategy. And finally, bump those commercial rates against Medicare to get an idea how each contract is really performing at the service line level. So the goal is to work towards actionable insights to help you get to rational pricing. So here's an example of the type of analytics we think are going to be needed to survive in a more competitive environment. So here in this this example, we've got we're forecasting volume and price changes. And so if you think about price elasticity in grocery stores, I know it's hard to think of healthcare being this progressive, but you have to plan ahead and you have to be ready to keep up with market shifts and competition. So thinking a little bit differently. So regarding a pricing strategy, once you have all that data gathered, you'll want to identify areas where you're competitive and not at risk of losing market share. You'll be able to identify where you need to focus with regards to competition, what areas managed care should be maybe willing to sacrifice when they're negotiating, and of course you'll need to determine the timing, and more than likely it will be a multi-year phased-in approach. Once you get started, it's going to be important to monitor closely. I'm sure that hospitals are going to change prices, and you need to be ready to pivot as the competition lowers and negotiations occur. So another point is to encourage you to work with payers to achieve rational pricing. I don't necessarily expect a win here, but some might say you don't get what you don't ask for. So I know over the past 5 or 6 years we've had some clients approach payers, and the response is we just aren't equipped to do that today. But hopefully, with enough push, payers will get enough pressure and their willingness to help you negotiate will change. So my last recommendation is to establish a formal pricing policy. This is a document that lays out how the organization is priced today and how you want to be priced in the future. And so some charges may be set relative to a Medicare fee schedule. You can bring in commercial data or cost data or maybe a combination, and probably do it more at a service line or a line level. It's gonna be different. But for example, let's say a hospital decides to price all their labs at 360% of Medicare reimbursement rates, and maybe their room and board rates go at 90% of the local market, but not to exceed 105% of the statewide average. And then maybe radiology goes at 3 times cost. Some kind of variation like that that's rational, defensible, and is not just responding to what others do in the market. So this document not only gives you a defensible methodology, it will help you set prices in a uniform fashion, so when new codes are introduced, you kind of know how they fall and how to add them in without, again, disrupting the rational piece to it. So once the policy is determined, changes can go in for the first year. You'll just need to put in some type of caps. So maybe no item gets decreased more than 5–10%, or whatever your comfort level is. And that's going to depend on a lot where you're priced today and how low you need to go. But anyway, each year just apply the rules and you'll start to work towards your goal, and eventually you will get there. So with regards to timing, we recommend you plan 4 to 5 months in advance. And so a lot of you were 6:30, so hopefully you are getting ready or have a plan. With the challenge of rational pricing and the additional team members that may be involved, I really urge you to get started now. I've been involved in many projects like this where the time gets crunched and clients have to go with a second or third modeling scenario. They just don't have time to explore some of the what-ifs. So you really do yourself a disservice by not starting early.
Yeah, Taryn, I like this slide because I think it really puts it into perspective of how much time this really does take, especially considering all the new factors that we just talked about today with the mandate. So we are about to wrap up the presentation. I do have one final poll question for the audience, and then we'll close out with some closing thoughts and big takeaways. I thought it was a great conversation today with Greg and Tara. But we'd also like to hear from the audience. So if anybody out there has any questions that they thought of during Greg's part or Tara's answers, feel free to enter those in our question tabs in your GoToWebinar pane, and then we will be happy to take those at the end of the presentation. So let's go through with our final poll question today. So how are you planning to complete your Chargemaster review to prepare for 2021? Are you planning to do this internally? Are you planning to use a third-party vendor or consultant? Or maybe you're not sure yet. So we'll give everybody a few seconds to answer this poll question. And again, if you do have any questions, the best way to get those to us is to just type them in your questions tab in your GoToWebinar panel, and then those will come through directly to us. So most of the audience has responded, so let's take a look at these results. I think these are pretty interesting as well.
I'm surprised at how many are doing it internally.
Are you? Yeah. So a third of you are planning to do this internally. About 27% are going to work with a third-party vendor or a consultant. And then this surprised me a little bit, 40% of you aren't sure yet. So any thoughts on that, Greg, Tara, as organizations start to prepare for this?
Hurry up.
Yeah, I think it's important to sort of tie that back to what we saw earlier with the fiscal year end. My assumption would be those that have a 6:30, which is about a third that we're coming up. You're probably doing that internal. Those that have a little bit more time, that may be tying into why you're not sure, and you may be looking to incorporate some other outside resources to help with that process.
Thanks, Greg. And we're going to finish up with just some closing thoughts here from Tara. So, Tara, as we finish up today, what are some questions that hospitals really need to be asking themselves as they prepare for their next Chargemaster review?
Well, I guess just to kind of recap some of the things I went over, thinking about what you're doing with professional services and pharmacy supplies. Is there any areas that you've neglected? And for those of you who are contracted with someone, you have a handle on what it is you're going to do, ask your current vendor how they're planning to help you and find out how they model the data. The devil's in the details, so you need to understand all of it around accuracy and revenue forecasting. And lastly, what is the organization's plan to move towards rational pricing? Whether you're doing it yourself or someone's helping you, you need to understand it. You need to make sure something's in place. Sure, it might be easier if the mandates disappear, but we all know that rational pricing needs to happen in the industry, so I think it will be less challenging for organizations if they get started early instead of waiting until it gets pushed upon you.
Yeah, absolutely agree with that. So let's go ahead and see if we have any questions here from the audience. And just bear with me 1 second while I pull those up. All right, so we have a couple of questions that came in from the audience that we want to take here. So I'm going to pitch this one to Greg. Greg, are the AMA CPT codes no longer considered proprietary information?
Yes and no. They're still considered proprietary information, but the AMA has come out and said for the mandate and the need to publish this information, there is a waiver, if you will, that you can publish your CDM file with CPT codes and still be compliant with the AMA CPT rules that they have out there. We could forward some information out to the audience with that information from CMS.
All right, thanks, Greg. Another one that just came in, so this is related to the Shoppables. If your integrated tool does not have all payers loaded, can you direct patients to call a phone number to still meet the requirement?
No, you're going to have to post both for the Shoppable services and your CDM standard charge file, all payers and all plans. The only exception would be your Medicare and Medicaid rates because those are already public information. But if you do have Medicare Advantage or Medicaid Advantage plans, you're in essence going to still have to build the Medicare methodologies to post those. You can have a call-in number to provide guidance or information, but you still have to post all payers and all plans to meet the mandate.
Okay. All right, Tara, I'm going to ask this one to you. How does this strategy vary for critical access hospitals? And then what is advice for very small CAH hospitals?
Yep. Well, we know that critical access hospitals are included in the mandate. But yes, being paid a percentage of cost makes things a little bit different. Some of the same things apply. The lesser charges become less of an issue. The payer mix, I would be interested before I answer this question to know a little bit more about how much commercial and what the competition looks like. But happy to talk one-on-one and a little bit more about critical access hospitals.
All right. Thanks, Tara. Next one. How long does it take to implement a new consumer tool for pricing of services, and how would we find one?
So from an implementation timeline standpoint, you should probably plan on anywhere from a 90 to 150 day time frame for standing up and implementing both a price transparency approach and a consumer friendly self-service estimate tool. In terms of how to find one, you obviously could go to our website. I sound like the political candidates last night during the debate. But you could go to our website and request information. You could also, I'm sure, do a Google search for self-service patient estimate tools. Would be another way of finding other vendors that may be out there.
All right. Next question. Does a requirement include professional charges if the physicians are employed by a medical group and not by the hospital itself?
Sure. So I think the mandate says that if they're employed by the hospital. So it's been a little bit of a gray area. We have gotten this question so many times, and CMS has not been clear. Do you agree with that, Greg?
Yeah, CMS indicated in the final rules that they were not going to provide that level of specificity with how your contractual relationships may be with professionals. Obviously, if you have employed physicians and you are billing for those employed services, you should be clearly including that in your standard charge file, and it should be clearly designated in your shoppable list. CMS took one step further, and they provided guidance, if you will, but not necessarily a mandate, that if you have some type of contractual relationship, and a lot of organizations have umbrella companies where the hospital is one component, medical groups are a separate component, you should still be conveying, it's not required, but you should be conveying, if we're going to be transparent with our relationships and our charges and information, we should be communicating that to the consumer, what those relationships are. But again, that is not a mandate requirement. In the mandate, it is only for employed, which I think most are viewing that, as Tara noted, a direct employment relationship where you have specific CDM charges, specific contractual rates and terms for those billed items.
All right. All right, next question. Do you only include contracted payers?
I'm not 100% sure on the question. Do you only include contracted payers? I'm going to assume that's referring to the price transparency mandate, where they do reference contracted payers. You do have to include all contracted payers. Obviously, if you don't have contracted relationships with payer organizations, you would not need to include that. If I missed your question or the intent of the question, email us back after the call. We'll follow up with you.
Thanks, Greg. And this is actually a follow-up to a previous question. If you have the integrated tool built for the 300 shoppables, but not call payers, the CDM will have all payers. It was a little bit unclear, but Greg or Tara, do you have any insight into that?
Yeah, so if you've got an integrated tool built for your shoppable items, it will have to be for all payers. The CDM, your CDM should be set up for all payers. Your shoppable items should be set up for both all payers and all plans. Obviously with the mandate, CMS did lay out the target date. There are some organizations that we've met with that recognize they're going to be challenged with standing up their internal tools by 1/1/2021. That may be an area, and we're seeing this with other organizations, where they're going to be posting a shoppable file in 2021 as they finish building out their self-service estimate tool. So that may be a strategy that you would want to consider on a go-forward basis.
All right. Thanks, Greg. So I think that wraps up our Q&A. I didn't see any more here in the queue, so we'll close things out today. And I'd like to get both kind of closing thoughts, big takeaways from both Greg and Tara as we wrap up today. So, Greg, what are your big takeaways from today?
Yeah, thanks, Brad. So, what we outlined today were specific tactical steps or tasks, if you will, that you must do to be compliant. And we also provided some direction with how to begin moving forward from just annual strategic pricing to a more rational pricing approach, if you will. Obviously, to really win going forward with price transparency, you're going to have to adapt. You're going to have to be strategic. And as we covered today, our strategy is going to have to shift so that it is both explainable, defensible, and more importantly now, rational. We have, as an industry, played the shell game for a lot of years where we've been able to shift reimbursement to commercials, payers where we received lower reimbursement for certain groups to shift it over. We've done the same type of shifting with how we've set charges over the years. So that's where it's going to have to be more rational as consumers start looking at our charges, they start looking at and seeing our reimbursement. It's going to have to make more sense. It does make sense for us today with a lot of hospitals to our bottom line and how we operate, but it's going to have to make sense to a broader community because we can no longer just fall back on the rationale of, well, it's very complex, you just wouldn't understand. We're going to have to help educate the consumer in the market to really understand how all this works. And that's really where PMMC can support your organization with both strategic steps as well as tactical direction. We obviously recommend defining what price transparency means and then developing the strategy that supports to that direction and then aligning all departments along with the executive team there. We can help clients meet the mandate by creating the 2 outline files. And as Tara covered, we can help your organization manage the process going forward. We're really capturing new market data, new methodologies as we go forward. And we look forward to speaking with many of you guys this year. We look forward to more calls as we go through the year and work towards the 1/1 mandate coming up. Tara?
Well, I think you summed it up nicely, Greg. Appreciate it, and please don't hesitate to reach out if there are any questions.
Thanks, Brad.
Thank you, everyone. We will be sending out a copy of the slides, and we also recorded today's session. So you can be on the lookout for that coming from me within the next day. So again, thank you, Greg. Thank you, Tara. I thought it was a great discussion today, and thank you to everyone who joined us today.